Welcome to Dementia Friendly, Prince George's County, Maryland Northern Sector webinar series for caregivers. Today's topic is dealing with behavioral issues with dementia, presented by Ann Cranon, and sponsored by the Prince George's County government and the Department of Family Services. Good evening, everyone, and welcome to the Dementia Friends of America webinar series. We are so glad you are joining us tonight to learn more about dementia awareness and how we can build a more supportive and informed community. My name is Caesar, and I am honored to be here on behalf of Dementia Friends of America and our local DFA Northern Prince George's County initiative. Tonight's session is part of our ongoing effort to increase understanding, reduce stigma, and provide meaningful resources to individuals, caregivers, and professionals impacted by dementia. Before we begin, I want to share an important opportunity. In partnership with the Alzheimer's Foundation of America, we are offering free confidential memory screenings for adults who would like to better understand their cognitive health. If you would like to receive a screening, please call me at 202-891-0791. We also invite you to consider becoming a dementia friend through a short online training. You can learn how dementia affects daily life, how it improves communication support skills, and how to help create a more inclusive and understanding community. It only takes a short time to complete, and you'll receive a certificate upon completion. We also know that dementia impacts not just individuals, but families and caregivers as well. That's why we offer free caregiver support groups that are both in person, and these groups provide a welcoming space to connect, share experiences, and receive encouragement. We also offer memory cafes that are a stigma-free environment for individuals with early stage Alzheimer's disease, mild cognitive impairment, or other dementias, along with their caregivers and loved ones.
Glad to be here and talk to you guys about this, what is really an important topic, and one of the things we are the most concerned about when someone we care about is being impacted by dementia. You can go to the next slide. Oh, I did want to say my thanks to Ann Morrison. I attended a workshop some years ago where I learned so much about behavior and dementia and how to manage it. So you can go to the next slide. And I think if you don't learn anything else tonight, learn this: behavior is communication. And the whole problem is figuring out what are they communicating. Is the person whose behavior is becoming a problem could be in pain? Are they sad? Are they lonely? Are they hot, cold? They're bored. They don't know what to do. They have no purpose. They're in a noisy room and they need it to be quiet. You're rushing them. That's something that never works with somebody with dementia. They can't understand what you're asking them to do, or they're frightened, or any of a myriad of other things. But I think that's the most important piece here, is that a problem behavior means this person's trying to communicate something. Next slide. Unaddressed behavioral issues for caregivers, this is no surprise here. They become burdensome to you. They can be unpleasant. They can be embarrassing, either for you or your loved one. My mother had dementia, and I recall how difficult this situation was. They increase your risk of burnout. They increase the risk of somebody needing to be placed because you've got these behaviors you don't know how to manage that are disruptive. They increase the cost of care. A client, a patient whose behavior is not well managed, they go up in the cost, not just because you might have to place them, even if they're already placed. Well, now they're at a higher level of care because they are resistant or whatever. They increase morbidity and mortality for caregivers. I think this is important to note, that dealing with these behaviors when they are unaddressed is got negative consequences for you, for the caregivers. And these behavioral problems are seen at some point during the illness in 90%, almost everybody with dementia. Like for instance, like I said, my mother had dementia, and good 80% of the time her behavior was not really a problem. But when it was a problem, it was a problem. Next slide. Um, Behavior problems are not the fault of your loved one, um, but they are a result of their disease. They are suffering from brain failure. You know, if somebody has kidney failure, heart failure, liver failure, we don't blame them. Somehow brain failure, and we expect them to behave differently, which just isn't fair. And we blame ourselves also not fair to us. Let's see. Next slide. So the upshot of all that is you have to become a detective. You have to try to figure out what they are trying to communicate or what they are communicating. And next slide. So the first place you start is you think about this person. You think about their family culture, their medical history, their lifelong habits, work, lifestyle, their religion. All of these things can have an impact on their response. If you've got somebody from a very conservative culture, and when it's time for shower or bathing or whatever, and somebody's trying to help them, and they can be very resistant because they're trying to protect their modesty. That's one example. There are so many of just our background affects us. Our habits affect us. Next slide. So the other thing is when you're identifying, you're getting to know that person, or that person, you think about that. You also have to identify the problem behavior before you start trying to fix it. You got to think about it. When did it start? Is it a new problem? Has it been growing and it's just now getting to where it's becoming an actual problem? Does it occur all day long? Does it occur only in the morning, only in the evening? What preceded the problem? Sometimes you'll find it's a particular person walks in the room. We had a caregiver for my mother who thought she needed behavioral medication and all this, and I'd never had this problem before. And finally, kind of came to the conclusion that the caregiver was actually the problem. She was assertive, and my mother did not respond well to her being assertive. Is it related to what's happening in the home? Is there a lot of other noise in the home? Somebody coming home from work or from school, and it's distracting. How does it relate to their family, to their social history? So, thinking about all of that as you're identifying the problem behavior. So you need to know all those things, or identify those things, and then identify the sources of the behavioral issue. And there could be, I'm sorry, you changed slides there. I didn't tell you. There could be multiple contributing factors. Might not be one thing, might be multiple things. You can go on to the next slide again. And so then the investigation begins. So are the behavioral issues, in quotes, actually expected behaviors within the context of dementia? Is this person, in other words, are you frustrated with the disease, or is it a behavior? Are they exhibiting amnesia? And we're all more familiar with amnesia, that partial or total memory loss. Is it related to aphasia, which is that language abilities being disrupted? Is it agnosia, the inability to interpret or recognize the input? They may not understand what's being asked of them, or what's going on in a space. Apraxia is the inability to perform particular purposeful actions. So we're going to look at each of those a little more so you can think about that. So with amnesia or memory loss, what the behavior you might be getting is the repeated asking questions. And they, as you all may experience, within minutes, they're asking the same question, or they may forget that their family has come and visited. They may lose belongings and accuse other people. They may, 5 minutes later, forget that you just gave them dinner and they're asking for food. They might stop in the middle of a task they're doing, like getting dressed, and they don't know what's coming next because they've forgotten. So, ways to address those behaviors, of course, be patient is going to show up everywhere. Be patient. And then set up a routine of activities can be very helpful so that your day kind of flows. And over time, they may learn to expect that. And I often would say, develop a routine of the day and post it uh, in the living space. We get up, we have breakfast, we have quiet time or television time or whatever, and then we're going to go out and kind of give them if they're still reading, an ability to kind of see what their day could look like. Um, Give directions one step at a time. Early on in dementia, you can say, "Hey, could you go in and get dressed?" As time goes on, that's not helpful. Put your arm in here, and then it might be guide their arm in, and you need to be willing to. This again requires patience. Repeat things as needed. Um, Secure belongings. Label everything, and um, use distraction when necessary. If they're upset or if they're asking something repeatedly, try to redirect them and offer reassurance. That's so important for someone with dementia. Okay, we can go to the next slide. So, aphasia is the loss of ability to understand or express speech. So, we might be familiar with aphasia when someone has a stroke and their speech has become difficult to, garbled, difficult to understand. But aphasia can also refer to the inability to understand speech. So that um, that might result in them over here on the left side seeming uncooperative because perhaps they don't understand the instructions you're giving them, even though it seems patently obvious to you. They may strike out if they can't communicate needs and wants, or if their needs and wants are being ignored. They may physically strike out. They could become isolated, which is something to always watch for because they're not comfortable with their ability to communicate. And so they kind of withdraw. They could misinterpret what you say and think you said something else altogether. So, again, we're looking at how you manage it over here on the right. We're looking at eliminating distractions. So I can remember having to make a room kind of quiet or asking for no interruptions when I would be, for instance, feeding my mother. And one of my kids would come downstairs to ask a question. And I finally said, "Look, when I'm feeding Mama, because if she was eating, if something distracted her, that was it. Her meal was over. She wasn't going to open her mouth again." I said, as a lovely mother that I was, if a bone is not protruding and blood is not pulsing, your question can wait until after I've given Mama her dinner. Because they lived in the home with her and she was in a separate space and it just wasn't, we couldn't keep doing that. And they understood. It just took some getting used to the fact that they couldn't come down just to ask a simple question, which seems very like a reasonable expectation from your child. But we had to eliminate that distraction. Um, Speaking to them, eye contact, eye level, kind of getting, if they're seated, getting down to where they are, getting their attention, speaking directly to them. And um, and you may need to use a low tone of voice because they may feel like they're being yelled at, whether they are or not. And if you're getting frustrated, your voice gets louder. Just kind of speak slowly, use simple words. It's so hard when you're dealing with people with cognitive loss who, perhaps were very verbose, could be highly intelligent, could have a great vocabulary. You still need to simplify things. You need to be willing to repeat yourself. Wait for an answer. Listen for keywords. Sometimes you'll get a lot of garbled speech, but you listen and there's a word in there. Um, and that's enough. Like with my mother, I can remember she was all upset one time and she was talking about my dad who had been gone for years. And I'm still trying to figure this out. What was she saying? And she was actually looking for him. And once I, you know, geared myself up to tell her that he had passed away. She was like, oh, well, then it made sense to her that he wasn't there. But it took me a long time to figure out what she was actually saying. Observe nonverbal behavior. That can give you a clue to what's going on. They may be, cold. They may be trying to communicate they're cold, they're hot, and you've got to look at what they're doing. And then you need to also, or could also use nonverbal gestures, like you would for someone who's hearing impaired, like something to kind of, this is, point them the direction they're going. And again, big surprise, be patient. Next slide. So the next one is agnosia, which we're often a little less familiar with. That's that inability to recognize or interpret input, sensory input, light, sound, touch. They may not recognize what they're seeing. They could be opening cabinets and not know, where to put a dish or where to get a bowl because they don't recognize what they are looking at. Problems that you would see there is, they're not recognizing what they see, they taste, what they feel, and they could try to eat non-food items. They could not recognize regular, family members who come regularly, familiar caregivers. I had an interesting story with somebody who didn't recognize themselves in the mirror. And our fix finally was to cover the mirror because this man thought his wife had a gentleman guest and he just didn't recognize himself. And he was pretty upset. They may walk into obstacles because they just don't recognize that this thing is in their way. They may want to go home when they are home. And so some of the responses here is you need to make the environment safe. You need to lock away items that they might use unsafely, things that are not food items if that becomes a problem. Another thing that can be helpful is introducing yourself. You go in the room and you say, hey, Mom, it's Ann. Hey, Dad, it's Ann. Just not like you're, you don't want to be speaking dumb down to them, but just like assuming they don't see and recognize you. Just kind of, hey, it's Ann, da, 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 da. Just kind of introducing yourself to make them comfortable. If they're not recognizing themselves, you may need to close blinds. Sometimes people see reflections that can be distressing. They may see lights outside that can be distressing because they can't interpret that. I had somebody who thought that there were, when somebody drove up and down the street, they thought people were coming to a party at their house and they weren't ready. And that was distressing. Avoid mirrors. Cover mirrors is another option. Keep clutter to a minimum so they're not walking into things. And if they want to go home, I would say this: distract and reassure them. Sometimes it's, oh, you know what? I bet it would be nice to see. They're usually going back in time. I bet you'd love to spend time with your mom, wouldn't you? Oh, yes, they probably would. And that's likely not available. So I would, just suggest having a talk about going home. Yes, let's plan a trip sometime. You don't have to actually do the trip. They're not going to remember that, but you're validating their feeling, which is they're missing something. They're missing home, which may be, the home of their childhood. It may be the home of 20 years ago. Who knows? All right, next slide. Excuse me. I need to take a drink here. So apraxia is the inability to execute a voluntary motor movement despite normal function, expressing normal muscle function. So I might be able to wave my arms around and do all that, but I might not understand how to get my arm in the sleeve. I might walk just fine, but all of a sudden you want me to walk and I'm not able to. And it seems like not willing to sometimes. Things that you might see is they're putting their clothes on backwards. They don't shave. They're not brushing their teeth. They don't know how to use a knife and fork. You have to cut up their food for them. They may not be able to feed themselves. I mean, brain failure can be very pervasive. So again, be patient, observe what they can and can't do, where the process breaks. Maybe they can't cut up the food, so you cut up the food and then they're good. Maybe they need you to put it on the fork. Maybe they need you to hold the shirt so they can put their arm in. Maybe they actually need you to guide their arm in. It depends. So you're modifying the processes and simplifying them. That's when you go to elastic waist pants and skirts and whatever, or the old fashioned like house dress for women, if that's warm enough for them. Things that are make it easier for you. They may have always worn a button down shirt and a tie. This It's time to change, and it's hard because then you're seeing them differently. They're being presented differently than they were, but this will minimize frustration if you are willing to make the changes. Um, Providing items in the order of use. If you lay all the clothes out or expect them to go get them, who knows what you're going to end up with. But handing them their underwear first, or helping them put on their Depends, and then handing them a shirt, and then helping them with their pants. Another thing that can be useful is just using finger foods, kind of migrating to at least some of the meals not needing to be fed. They can reach over and get a sandwich, that kind of thing. They also talk about using hand over hand cueing. So you might be able to get them started with your hand on their hand, get them started with eating, or started getting dressed, or whatever it is. Um, and they may be able to continue on once you've gotten them started. Let's see, next slide. Um, do you have this one that says anosognosia? I don't think so.
No, I'm on investigation continues.
Okay, so I inserted a slide tonight because I remember reading about this, and you won't have a slide. But anosognosia is another impairment, and we see this a lot. It is a common symptom that prevents people from recognizing or acknowledging their own impairment. And the first time I heard about this, I thought, well, duh, people with dementia don't realize they have dementia. And it kind of is a duh, but also there's real frustration for caregivers when they're blaming you for everything because they think they're doing everything just fine and don't recognize a problem. And so I didn't like fluff all that out on what you would do, but I think it's something to be aware of, that this is a problem for caregivers, is the complete lack of awareness or willingness to acknowledge a problem on the part of the person they're caring for. So now we're on investigation continues. Um, so then, in addition to all of those other pieces, now you got to think, are these issues related to any medical problems? In other words, is there something other than the dementia that could be causing the problem? Especially with anything abrupt. There could be pain. For instance, I had a client who was so mobile. And I went to visit her one day. She was in a facility and she would not get up and walk. And it was like something odd. This like changed from the day before. And turns out she had a broken hip. Nobody had seen her fall. She could have fallen in the night and gotten up and gotten back in bed because it wasn't displaced. But she had a broken hip. You don't want to miss something that's really causing a problem. So if they're unwilling to move, they could have a shoulder issue. It just depends. You need to pay attention to these things, particularly something like that comes up suddenly. Is there confusion that is new for that person? There's dementia, and then it could have changed dramatically. So it could be something else going on. Are they at a lower level of consciousness? Are they hard to waken? Is there an acute onset of delirium? Does it fluctuate? Has there been some new meds? There could be a cumulative side effect of meds. They could have an infection. There could be a new medical problem. They could have a stroke. They could have an electrolyte imbalance. Next slide. People with dementia express pain very differently. They may not wince or grab at the painful area. They may rock. They may just get agitated. They may shout. They may refuse to eat. They may not sleep all of a sudden. So you can't count on them, and you can't count on asking them and getting an answer. Are you in pain? You might have to touch, to feel, to, kind of um, parse it out. And you might need to advocate for them. If they can't reliably self-report pain, you might need to, get some medical emergency. Something's different, and be confident. Something has changed here. Something's not right. You know them better than anybody else. And so this is your opportunity to do that. Next slide. So physical medical problems, I think we kind of covered this. Could be from infection, delirium, a chronic or a new illness, pain, sensory impairment, unmet needs. Can also be medication change, medication withdrawal, medication overload. Next slide. So then you got to think too, are behavioral issues, are they related to the mental health or complications? And some people have a history of mental health. For some people, some of this comes with dementia. And I remember talking to somebody and they were saying, gosh, their dad or mom, I don't remember, had been diagnosed with dementia and they're worried about how they were depressed. I'm like, well, to me, this makes it seem like they're having a normal response. I think that is a normal response to a new diagnosis of dementia, is to deal with some depression or some anxiety. So depression can be associated with just irritability, anxiety, nervousness, worry. And you'll see that sometimes with people where they're just worried about who's coming home. When are they, when is so-and-so going to be home? When is dinner? They may or may not be hungry. They just want to know, when's the next thing? That's back to what I said earlier. Sometimes, putting up a agenda for the day can be helpful. Apathy can look like just resistance to care. Psychosis usually means delusion is more common than hallucination. Hallucination is when I think I see something that's not there. You'll see people talking to someone who's not there, that kind of thing. Delusion is they believe things that aren't true. So behavioral issues like this usually have a slower, gradual onset. Doesn't mean they don't need to be addressed. Next slide. So I think one thing is to consider, were there mental health issues before the dementia? And frankly, in the senior population, more so than the young adults now, diagnosing mental health issues just often did not happen. We just assumed, you just put up with people's issues. You didn't meet them head on. And so you've got people with issues and somebody, was this a new problem or is this lifelong? Oh, it's lifelong. Okay, well, then we're probably not going to address that. If it's new, we're probably not going to be as successful at addressing it. Let me say that. But if it's new, then we might be able to do some things. Do the behavioral issues precede the dementia? Oh, wait a minute. Behavioral issues that are related to prior illness precede the dementia, and they may persist, they may diminish, they may worsen. I dealt with a woman who had some mental health issues, and some of it resulted in that she had been pretty much a racist. I don't know what else to say. And with dementia, that went away. It was confounding. It was amazing. And it was a blessing to the family and to the caregivers that this was gone. It was hard for the family to deal with because she had been a pretty difficult woman, and that this, some of these difficulties just went away. And then you've got all the baggage that comes with having dealt with somebody who was difficult through life. Are the behavioral issues related to mental health issues, complications, associated symptoms? This will inform how you proceed. Doesn't mean that other interventions won't help also, but having an understanding that there are underlying mental health issues is key to resolving things or addressing. Next slide. And then you look at Are the behavioral issues related to the environment? Is it a noisy home? Is there a lot of are there a lot of distractions? Is it hot? Is it cold? Are they overstimulated? Um, I noticed when my mother lived with myself and my 4 kids, for several years, she would have um, evening dinner with us. And then over time, it just got to where she was, I had teenagers talking. And, frankly, if your teenager's talking to you, you want them to be able to talk and you want to listen. But she could not handle all of the conversation that was going on. And so eventually we just started saying, you know what? I'll have dinner, I'll go downstairs and give Mama dinner, and then I'll come up and have dinner with the family. And that that worked for us. Is there a lot of chaos and clutter? That's another thing to look at. Physically, like if there's a lot of just visual clutter, for some people, that's an issue that can cause anxiety. Next slide. Um, so when you're dealing with the environmental factors, you need to evaluate the surroundings and eliminate distractions. You may need to turn off radio or television or turn the volume down. You might need, as I've said before, provide structure and scheduled activities and remove other people when appropriate. It doesn't necessarily mean that this other person is inherently a problem, but your person with dementia may have problem with, um, for instance, could have problems with a man who comes in, could have problems with a male caregiver. A woman may. And there's other things. We just don't know what's going to set somebody off. But as you're observing, if it becomes a consistent thing that this visitor is a problem, then what you might do, if you want that, that daughter, that whoever to be able to visit is, you might have those visits supervised. You might limit the time, that kind of thing. That might not be a person you give kind of unfettered access to the person you're caring for. Next slide. Um, so finishing up that investigation, you also think about, are things related to the structure of the day? Is there poor scheduling? Is there a lack of routine? Has there been a change in caregiver, a change in location? The season changes, it affects our routines and may affect this person that you're caring for. Do we not consider preferences? My mother, again, very resistant to bathing for a while. And finally, we figured out, and I just made her bathroom on shower day. We did a couple of things, made it more like a spa. So we made sure it felt nice. I took her terry cloth bathrobe and her towel, and I put them in the dryer and had them getting warm. And then I was available to help. We had a caregiver to help, and I wore my nylon clothing and I got right in the shower with her and just helped her, and she felt more secure. And over time, she became much more cooperative with her showers. And boy, she liked that warm towel and robe when she got out, and she was way more cooperative. But it's trial and error that helps us to find these things. And when you think about preferences, I don't know about you guys, but I have a routine. When I shower, I wash my hair first. It's just the way I do it. But somebody who has lived doing things a certain way for many years, and someone else comes in and takes over their care, it may not go well because it's different and they like their routine, and they may or may not be able to communicate that. So I think one thing is observing them. If they're showering on their own, where do they start? What's their routine, so that as you need to help them later, here's the way mom or dad did this. Next slide. Um, sadly, are the behavioral issues related to the caregiver approach? I can so relate to this face sometimes. Am I hurried? Am I being impatient? Am I angry? Am I argumentative? Am I demanding? Um, and one of the things there would be, I like to be really efficient with my time, meaning that I use every minute up until the time I'm ready to walk out the door trying to get something done. which often leads me to be just a couple minutes late. Well, when I was taking my mom somewhere, you can't rush someone with dementia. You need to start an hour before you need to get out the door and to get them ready. And you know what? If you happen to be ready early, just go ahead and leave. But I would get really frustrated with her just moving slowly. But she had dementia. And so I don't know that I was argumentative, but I was demanding. Come on, mom, let's go. Let's go. We got to go. Let's go. And that certainly wasn't helping her. Could we have inappropriately addressed the problem? Um, Sometimes we're just unkind in the way we say something, or we've identified. Uh, I had another instance where a woman was sitting in the car with her husband, and she was so upset she had dementia, and you could see the husband getting frustrated. And what had happened is the car door on her side of the car was still open, and he didn't realize it. So she was, with her behavior, trying to communicate something, and he's just trying to figure out why she keeps moving, and he hadn't stopped and realized, because he's looking at her and she's upset. Anyway, you just have to be a good investigator and look for what could be the issue. Next slide. So you evaluate your approach. Kind of talked about this. Are you greeting? Are you identifying yourself? Are you rushing them? Are you being demanding? Put this on. This is what I want you to wear. Are you arguing? Are you trying to reason through something with them in a way like you're not going to get a person with dementia to understand your reasoning. That's just not going to happen. Are you being inflexible? Does it really matter that they wear the thing you picked out? Do they need to do this thing first? I have found, I can remember having children where I was inflexible about some things. Like sometimes we get a bee in our bonnet about something, and it's really, that wasn't essential that it be done that way. So that's another thing to look at. Next slide. And then you start making modifications. You can plan rest periods. It's often good to have rest in the morning, a rest time in the morning, a rest time in the afternoon, to alternate high and low stimulating activities. You're not going to be able to do all your errands that you have to take this person out in one day. You've got to space it out. They may be able to handle one or two things. Watch them, observe for signs of stress and frustration. When you start seeing reactions, reduce stimulation, make it quieter, turn off the radio, whatever it is. Retreat. If somebody is really resistant to whatever you're trying to get them to do, you stop the activity, you redirect, you may rest and come back later. And then consider the things are their preferences, their habits. What would be the way their personality was? Another funny thing that happened to me with my mother is I fixed a dinner one night that she had served us countless times when I was a child. So I thought she'd like it. And it was a tuna casserole that she served us many times, not saying tuna casserole is the greatest. And she said, "What is this?" I'm like, "Well, this is this tuna casserole." She explained to her, "This was your recipe." I wouldn't have served that to anyone. Like, okay, mom, like, let me get you something else to eat. Preferences change too. Next slide. So then it's time to really devise a plan. You can change one or more of these things. Change the caregiver approach, make changes to the environment, change or implement a schedule or routine, employ a behavior specific intervention. So if they're striking out, then there may be something that you want to change that you think could be causing that. And so you make these changes, and then next slide, you implement the change. Make sure you have a clear goal. Make sure everyone knows, everybody involved. If there's other family members, other people in the home, make sure they know, here's what we're doing, here's why, because consistency is critical. Doing it the same way all the time, keeping that schedule change consistent, it's going to make a difference. Next slide. Caesar, what are you looking at now, slide-wise?
Determine if it works.
Okay, good. I wanted to be sure. Thank you. Um, so then you kind of watch, observe what occurred when you made the change. Did everything happen the way you hoped? What worked? What didn't? Do you need to make any adjustments? Do you need to change the plan? Um, Many times it's small things. It's a little thing. You don't need to go through this very robust investigation, whatever. Like, oh yeah, maybe mom's just too much stimulation. Let me turn off the television, turn off the radio, whatever. You may not need to go through all this, but this is what's helpful when you're having a hard time identifying it. Um, make a new plan if you need to. Next slide. And what things to strategize with. Approach from the front. When you come up to somebody from the back, that can be distracting. Make eye contact. Greet them in a calm, friendly, pleasant manner. And I think, particularly as family members, we have to remember we're not only their caregiver, we're their sibling, daughter, spouse, whatever it is, and they want more than just you as a caregiver. Um, be sure that their hearing aid, their glasses are being used when appropriate, that they have those things. And then use humor or cheerfulness. When we go in stressed, they're going to pick up on the stress. So sometimes, before I go in the room, I just have to kind of think, okay, I want to go in with a good attitude, because this is what they get. They get me. Um, Adjust your expectations to the abilities of the person you're caring for. I think that is so important, and it just takes time. It takes all that observing to figure out what are their abilities. Trial and error is important. Be creative. And sometimes I tell people, just get someone else's input, someone else's insight. I had a friend who was having a really hard time getting her husband to take his medications. And she said he used to take them, and now he had started biting her when she was putting meds in his mouth. He had dementia, obviously. I said, have you tried putting them on a spoon and just tipping the spoon in? And she thought I had come up with this. When it worked, I was just amazing. Well, it's not amazing insight. It's just, well, I'm not in the middle of it, so I can, think outside the box. And so sometimes having somebody else come and observe and give you some input can be helpful. Next slide. Um, General approaches. Uh, Adjust your expectations to their abilities. I've already said that. Trial and error, be creative. We've said that. Medication may be needed. It could be that they need a medication to address behavioral problems. It would not be my first go-to, but when you've tried these other things, it's time to discuss that. And then I've had people where behavior was so outrageous, they ended up needing to be hospitalized so that uh, the hospital could take some time and get a good cocktail of medication that was working. We don't want to snow people to over medicate them, but we do want to be able to provide care and keep them safe. That's important. Next slide. We're starting to review here. So some principles to remember. Preventing a problem behavior is easier than trying to fix it. So practice good, some of these things I've talked about. Going in and introducing yourself. Some of these things that just keep things quiet and kind of chill for them. Your loved one needs quality time that is not care related. They still need you to be their spouse, their sibling, their son, their daughter. Third, if you don't give them something to do, they will probably find something to do. And it might not be what you want them doing. So that's that, have an agenda, plan some activities. I often recommend making and this takes some brainstorming with people, but generate a list of things that you think. My mom used to sort socks and wash. When she couldn't do that anymore, then I would have her fold washcloths. Did I need her to fold washcloths? No. Did she like feeling useful? She really did, and it was important. Um, to give her that feeling of usefulness. But you might need other people to help you brainstorm what are some activities we can do. You can also do some like web searching and find a list of potential activities and then go through and pick out. And I say make a list, make a notebook, or if you're the digital sorts, share your file with other people who are in the caregiving role with you. And pick one or two of those on a given day. Don't do the same thing every day, but have a list that you can kind of go in and out of as you need to. Everybody in the care plan, all the family members, the other caregivers, need to be informed of any behavior management plan. Get them on the same page, get them to understand what you're trying to do and the reason. And, it just helps. Communication, so very important. Next slide. Reward the behavior you want to encourage. So when they do what you said, what you asked, oh, thank you, that was so helpful. I don't have any more to say about that. Sorry. Choose your battles. Figure out what really matters and what doesn't. I was alluding to that earlier. Ask yourself, does it matter if mom sits in this chair? Does it matter if she gets her shoes and socks on? Does it matter if she wears her bra? I had people who would battle over that. I'm like, she doesn't need a bra. It's okay. Keep your emotions in check and just kind of give yourself time. Sometimes step away if you need to, and anticipate that there will be different behavior at the end of the day. Save some of your energy to help get them settled for the evening, but also during time of like there's stress in the home, if they're ill, if they've got a cold, whatever, their behavior is going to be impacted because they can't tell you, I don't feel good, I need this, I need that. All right, next slide. And then take care of yourself. So important. Enlist the help of your family and friends. Build your own team that is supportive for you. Join a support group. Schedule regular time off for you. And actually, the person you care for would probably benefit from a day away from you or an evening away from you. And then, hard to do, I know, but find a way to build in time to care for your own health, your own exercise, your rest. Caregivers often ignore their own needs, and in the long run, taking care of yourself is part of taking care of the person you're caring for. And when you get time away, you will be better able to address all the behavioral issues as they come up. Next slide. Oh, yeah, we're here at the end. So here are some resources I have used and I like. This first book is Coping with Behavior Change in Dementia. It is something where you can you look up a behavior and then there are some ideas for how to manage it, like bathing, resistance to bathing, and there'll be a section on that. Then there's this book, Creating Moments of Joy, and the idea being, because someone has dementia does not mean they can't experience pleasure. And even when the event is over, if somebody tells me I looked good in a particular outfit, you feel that all day. Gee, I look good today. They may not remember that you had this great moment with them, but they will still feel it. And this book is really good at just helping you come up with, like I was saying earlier, activities and other things like this. For the caregiver, this book, the third one here, Finding Grace in the Face of Dementia. This is written by a Christian geriatrician, but just talking about how we are impacted by it and how we can take care of ourselves, but also how we can learn and grow from being a caregiver. I'm guessing that was probably the last slide, but I'll let you see. Oh, nope. Some more resources here. These are, if you guys have not heard of this woman, Teepa Snow. Her first name is Teepa. I've never heard that anywhere else. But she does an entire course that you can pay to take maybe you can find, I haven't thought about this before now, but maybe these videos are available through the library or something. But I have found some great excerpts from some of her videos on YouTube that one particularly I remember on de-escalating a crisis, but any number of these you can kind of look for, and oh, so she's just so helpful stepping kind of out of the situation and helping you look at it from the viewpoint of the person who has dementia, and which just makes it so much easier to provide care for them. And next slide. Oh, that might be the last one.
Yep, so if you missed any previous sessions, don't worry. All past webinars are available on our YouTube channel, and we encourage you to subscribe so you never miss future presentations. We invite you to please complete our short feedback form to let us know about any topics you would like covered, speakers you would like to hear from next, or suggestions for future programs. And thank you everyone tonight. Thank you again, Anne.
Thank you.
Thank you. Good night.
Good night.